So big turnout tonight, which is fantastic. 47 of us. That's brilliant. So, and Dima, just for your information, there's at least two clinical nurse practitioners, nurses, specialists on here tonight. One from Cardiff and one from Stoke, which is fantastic. And a lot of new people to me, which is also fantastic. So welcome, Dima. I'll just say a big thank you to Dima from the start off, because she has been busy tonight with this school parent parent meeting online. So that was very important. She had to get that out of the way before she came to talk to us, and she's going to talk to us about future treatments and the future treatment of WM, particularly in the UK. And I guess, Dima, without trying to steal your thunder, you're going to be talking about the good news surrounding zanubrutinib, which Roger has just been telling us about. He's on zanubrutinib. So I'm going to hand over to Dima, and if any of you get any questions, you can either put your hand up by going to, I think it's reactions at the bottom. Yeah, if you press on the reactions button, and you can raise your hand, and I'll come to you at the end of Dima's talk and we'll ask those questions, or just wave at me when we ask for questions. That'd be great. So Dima, over to you. Thank you.
Thank you. And you'll be pleased to know I'm in a very good mood because the teacher said how great my son is at doing at school. So that always is a good start to the evening. So hello, everyone. For those that don't know me, as Bob said, I'm Dima El-Sharkawi. I work at the Royal Marsden. And I thought I would talk a bit about kind of general principles about how clinical trials are set up and how drugs are developed, so that you kind of get an understanding of things with regards to WM. So more general points rather than a specific kind of run through of all the clinical trials in the world that are happening in WM. So I have got a few slides, mainly to remind myself about what to talk about. But if I share my screen, let me see if I share this one. You should hopefully all see the slides now.
Yeah, there we go. That's good.
Let's see. Is it going to let me? Yeah. So in terms of clinical trials and drug development, you'll hear people talking about different phases of clinical trials, and essentially someone's got a good idea, or usually a big company have got a good idea about a drug that they might think will work in WM, or often in lymphomas in general, before they decide to look in WM. They need to have a rationale and then also some preliminary proof that actually it will do what they think it might do. And that will come either from cell studies or animal studies, but essentially studies that occur in the laboratory before the drug even gets tested or tried by a human. But if that goes through that and they've got some encouraging data, then the first phase in terms of clinical trials is a phase 1 study. And when you read any studies, if you look up online what the latest drugs are in WM and what clinical trials are happening, the phase 1 studies are the first studies that happen with the drug. So they may be drugs that have never been tested in humans before, or they may be drugs that have been tested in other cancers, but haven't been tested in patients with WM or other blood cancers. And whenever you read reports of studies, one of the things that they have to put is the main objective of the study, what they're trying to get out of it, which if you're on the study might be slightly different from your objective, might be slightly different from what the study's objective is. But usually with phase 1 studies, the main aim is to understand the safety and the toxicity of the drug, so the side effects, rather than how effective it's been. So obviously, if you go on to a phase 1 study, you hope that it's going to be an effective drug, but the main aim of the study is looking at the tolerability and the side effects, and also finding the right dose of the study drug to move on to the next phase of the trial. And so then the next phase is the phase 2 study, where they start to look at the preliminary efficacy of the drug. So how good is it at what we want it to do? And often the phase 1 studies and the phase 2 studies are in few patients, not that many, because they want to get it to the phase 3 study, which is the thing that usually is going to mean, if it's a positive outcome, that they can get a license for the drug. Sometimes some studies combine the phase 1 and 2 parts, so they'll start off with a phase 1 section and run through to a phase 2 section. So you can get some studies that combine them. And one thing I guess to note with the phase 2 studies is that people want, from a trial perspective, early readouts to show efficacy. So efficacy from a trial's perspective, so how effective the drug is, may be different to what you would think of as a meaningful good outcome with a drug. So for example, often with phase 2 studies, the primary outcome or objective of the trial is actually how deep a response you've had in your WM, rather than the duration of response to the drug. Because, you know, if you, for example, with zanubrutinib, and I've got a slide with this example on shortly, if they want to find out that zanubrutinib's effective, then they would rather find out in 3 or 4 months' time, rather than wait a few years to see how long the effect has lasted for, because from a company point of view, they want to get through this part as quickly and as cheaply as possible to be able to get the drug out and people to start paying for it, essentially. And so, but if they get encouraging outcomes with the phase 2 study, then they'll move on to the phase 3, usually, where you compare the drug with the current standard of care. And the endpoint in this case, to be able to get licensed and funded in different countries, is often about the duration of response. So you'll see things reported like duration of response, progression-free survival, which is how long someone lives for before the disease starts to come back, and overall survival, how long someone lives for. So that really is the kind of the final part. And if that's a positive outcome and the company decide they want to take the drug further, then that often gives them enough evidence to get the licensing for their drug. So we'll use zanubrutinib as an example. So this was some of the data from the phase 1 trial, which was really a phase 1/2. So they were looking at the safety and the toxicity profile, so the side effect profile, as one of the main objectives, but also getting preliminary efficacy results. So in the phase 1/2 trial, it was trialed in 77 patients with WM, of whom 53 of them had already had treatment before, and the rest had zanubrutinib as their first treatment for WM. It's always useful to see if the characteristics of the people that have gone on to the trial are similar to what we would expect for patients of WM, because often trials may select patients that are younger, fitter, and maybe not reflective of the whole cohort of patients of WM, although everyone I saw on the Zoom call looked very young and fit to me. So the median follow-up was 36 months in those patients that have already had treatment before. So as I said, as they were looking for preliminary efficacy, they looked at the best response. So this is seeing if you start off with your paraprotein at, I don't know, I'm going to pick a number from thin air at 40, how much does it reduce by will tell us the depth of response. And you can see that we'll talk about complete responses, which is where the paraprotein disappears completely. Very good partial responses when it goes up over, you get a 90% or above reduction. PR, so partial response, is 50% reduction or more, and minimal response is you've reduced your paraprotein by 10%, but less than 50%. So that gives us an idea of the depth of response. And you can see that actually the majority of patients were achieving at least a partial response, so at least a 50% reduction in paraprotein. But the depth of response doesn't necessarily correlate with how long you're going to respond for. It depends on the drug that you're looking at, whether depth of response correlates with length of response. So you can't assume that if you get a deeper response, it's going to last longer with this class of drugs. And in fact, the American group have looked at with ibrutinib whether you can correlate depth of response with length of response, and they couldn't see any differences once patients had achieved a partial response with ibrutinib, whether you achieved a partial response or very good partial response in terms of how long you respond for. So I think that is drug specific. So some drugs it may correlate, but it doesn't seem to correlate as much with the BTK inhibitors from the data we've got so far. And then also with the clinical trials, you'll see a lot of curves like this, which are called survival curves. And what essentially is happening is on the x-axis at the bottom here, you'll have the time, which is often in months. And on the y-axis, it'll either be progression-free survival, time to next treatment, or overall survival. So it'll be something to do with the duration of response. And essentially everyone starts the clinical trial. So 100% of people start. And then where you see the little flicks here on this curve or this curve here is where patients have been censored. So if you can imagine, not everyone starts the clinical trial on the 1st of January 2020, or what it would have been earlier than that. Everyone starts the trial at different times, so everyone will have been followed up for different lengths of time. So we know from the numbers here, for example, that whilst there were the 77 patients in total that started the trial, actually in terms of follow-up, by the time you get to 4 years, only 11 of them are still kind of have been followed up for that length of time by the time they've reported this. So that's what those little flicks mean. But each time you see that the line goes downwards, that it basically means that someone's had an event. So that from this side, it'll either mean that they've died or that their disease has come back. So kind of the flatter the curve, the closer it goes to 100, and for the longer length of time, the better the drug, essentially, because it means that no one's relapsing and no one is dying. And obviously that's going to be impossible to have that 100% forever, but actually this is very good, encouraging preliminary data from an early phase trial where in patients either who have had treatment before or in those that have treatment naive, actually you see that the curves are quite close to the top, so very few people are progressing. So it's very encouraging data, and definitely what led to BeiGene moving on to the phase 3 trial, which was then, as I said, phase 3 larger studies. So you can see that now they've recruited 200 patients rather than the 77, and they're now comparing it to what they see as standard of care, which brings me to, I guess, one of the issues when you come onto the licensing, or really the funding side, is what's considered standard of care in some countries may not be considered standard of care in others. So it makes it difficult to really be able to use the trial data to help fund these drugs. And you know, we had that problem when it came to the NICE approval of zanubrutinib, that given that ibrutinib was not considered standard treatment because it hadn't been fully NICE approved, and now it's been taken off the Cancer Drugs Fund completely, they couldn't really take this trial into consideration at all, because they were comparing to a drug that we don't really have in the UK population, or that they couldn't consider, although in actual fact many patients had been on it previously. But this was the Aspen phase 3 trial, and you can see that in terms of depth of response, that possibly slightly more people getting a deeper response with zanubrutinib than ibrutinib, although there wasn't a significant difference between the two, so we're not really sure whether that's a chance finding or a true thing. But actually, when it comes to duration of response, that the two are pretty much overlapping. So we knew beforehand that ibrutinib is an effective drug for Waldenstrom's, and certainly zanubrutinib is at least as good as. But I guess, you know, that's a very positive result. And now in the UK, in England and Wales, we're able to give zanubrutinib in the relapsed refractory setting. So for people who've already had therapy before, but they felt there wasn't enough evidence to be able to fund it in those that haven't had treatment before. But you know, even if you get a very good result with your drug, sometimes the drug companies that make the drugs decide that actually they don't want to go the next step and invest the extra money to get the license and the approval, because I guess they don't think that they will make a significant return to warrant it. And I give this just as an example. So, you know, many of the centers that you will go to in the UK were involved in a trial looking at acalabrutinib. So this is yet another BTK inhibitor. So works on the same enzyme that ibrutinib and zanubrutinib works on. But there was quite a large trial of just over 100 patients looking at acalabrutinib in WM. And again, I mean, you can see that the survival curves are very encouraging, and this is very good data, similar to what we've seen with ibrutinib and similar to what we've seen with zanubrutinib. But after a positive study, the drug companies still need to make the decision to go ahead and get the license for medical and healthcare professionals to be able to prescribe it. And AstraZeneca decided that with their acalabrutinib drug that they weren't going to proceed to get a larger trial to get the license in Waldenstrom. So although we can prescribe acalabrutinib in other B-cell malignancies, they haven't proceeded with this in WM. So even with a positive trial, you still need the drug company to want to push it further to get the license. Oh, that's come back again, apologies. So I thought this might be quite interesting for you all to see. So as I said, it is a bit of a pyramid, and you do lose drugs between the different phases, between phase 1 to 2, from 2 to 3, and then from phase 3 to get approval and a license, whether that be on the FDA, which is the approval body, if you like, for the US, the EMA, which is the European approval body, or the MHRA, which approves it for the UK. So these are figures that I got from this paper in Biostatistics that basically try to mine all clinical trials between, sorry, my icon is hiding, between 2000 and 2015 to see how many of the trials or drugs that are tested in phase 1 move to phase 2, then move to phase 3, and then subsequently get approved. So this is in all oncology trials, not specific to WM. And what they found between those two time points, that 57% of phase 1 trials with a drug in oncology went to a phase 2 trial. Of those, 32% proceeded on to a phase 3 trial. So already most of the drugs never get to that phase 3 trial. And of those that make it to a phase 3 trial, about a third of them go on to get formal approval and licensing for use in whatever indication it was trialed in. And when they looked at phase 1 drugs, how many of them get to final approval, actually only 3% of those drugs in the phase 1 trial stage get to be approved. So you can see that actually, although, you know, I'm about to go in a few weeks' time to ASH, which is the American Hematology Conference, the largest hematology conference in the world, where there will be lots and lots of phase 1 trials that will include patients that have WM. But you can see actually the vast majority of them, whilst they all seem quite encouraging, often in the phase 1 stage, and a lot of them will go to the phase 2 stage, very few of them will get to final approval. So you've been through all the trials, you've got the approval, but then the next stage for the NHS perspective is, once you've got the license and approval, it needs to go through NICE to see whether it's cost effective for the NHS to fund it. And I think BTK inhibitors and Waldenstroms are actually a great example of this, because we've got 3 BTK inhibitors, all of which we know from trial data that they're effective in WM, but acalabrutinib, they never went on to get a license. Ibrutinib is effective and licensed, but when it went through NICE the first time, they were given kind of almost like a provisional in the Cancer Drugs Fund, where they're given 2 or 3 years to generate more evidence to show that it's cost effective. But then when it came for the final kind of application and approval, it got declined by NICE. So now if you're already on ibrutinib, then you continue on it and the NHS will continue to fund it, but they won't accept new patients to go on ibrutinib. And zanubrutinib is effective and it's licensed, and it was deemed to be cost effective, so it is reimbursed by NICE. But the other thing to say is, and zanubrutinib is an example of this, that sometimes NICE decide that it is cost effective, but not for the whole license. So zanubrutinib is licensed for upfront treatment if you are not suitable for chemotherapy, or for relapsed refractory disease. Whereas if you look at the wording from NICE, they are not funding it upfront for anyone. And for those that are relapsed and refractory, to make it cost effective, it has to be for someone that would have otherwise been considered suitable for rituximab and bendamustine. So there can sometimes be a kind of narrowing of indication, if you like. So going specifically onto treatments for WM, that's more of a general outlook on trial development. You know, we've got the standard chemoimmunotherapy, which has been around for decades, but we know is effective, but can be associated with side effects. There's proteasome inhibitors, so they're things like you might have heard of, like Velcade, bortezomib, or ixazomib. Now, they have shown efficacy in Waldenstroms, but they're not funded in the UK for Waldenstroms. We've talked about the BTK inhibitors, and of course, there may be clinical trials occurring, for example, like we've got some in our centre and in other centres across the country that may include patients with WM. So if you're offered to go on to trial, you know, we've been talking up till now about trials that are investigating new drugs, but not all trials investigate new drugs. Some of them are more about investigating what's the best order to give drugs. So, for example, one of the UK studies that's open in a lot of centres is looking to try and address whether it's better to have a BTK inhibitor up front or the standard chemoimmunotherapy. So that's called the Rainbow study. So those aren't new drugs, but it's trying to see, can we use the drugs in a smarter way by getting evidence to prove which is the better way, if you like, of giving things. If you're offered a clinical trial, you'll always be told, if you choose not to go on the clinical trial or you're not eligible, what the alternative option would be. So you'd be offered your kind of standard option and what you would be given on trial. Obviously, being on a trial is completely voluntary, and whilst we like patients to go onto clinical trial. It doesn't affect how we would manage you, and we wouldn't think anything differently of you if you chose not to go on a trial for whatever reason. And if you do decide to go onto a clinical trial, once you've read the written information, there will be a screening period, so you don't automatically sign the dotted line and then get onto the trial. We will need to go through a whole list of investigations to see whether you match all the what we call eligibility criteria. So some people may want to go onto a trial, but may not be able to. They may, as we call it, fail screening, for example, because their blood counts aren't high enough to go onto the treatment. So that you need to undergo screening to assess whether you're eligible to proceed to have the treatment. So then, in terms of future treatments for WM, I kind of think about it in two ways, and this is very simplistic, but I like to think about things quite simplistically. The treatments and how they're developing in WM is what to it's kind of looking at different targets and what is the best target. So, we've talked a lot about targeting this enzyme called BTK, but there are other potential targets that may be quite useful in WM. So some of the trials are looking at different targets, and then some of the trials are looking at targets that may be new or ones that we know about, but maybe targeting things in a slightly different way to some of the drugs that we're using now. So let me give you a bit of examples. So, I always say that chemotherapy is quite a blunt instrument for treating WM or cancers in general, because it essentially works by killing rapidly dividing cells, but it's not very smart therapy. And so a lot of the drug development now is looking at more smart ways, if you like, or targeted ways of treating the WM. And so, when we go to medical talks about new drugs that are being developed or drugs that are used in other cancers that may also be useful in WM, people will look at the pathways that we know are overactive in cells. So this is kind of a cartoon diagram of a cell, or your WM cell, for example, where this is the cell surface. So there'll be some drugs that target proteins that are on the cell surface themselves. So I think a lot of you who've had chemoimmunotherapy would have had rituximab as part of your treatment, and rituximab targets a protein that's on the surface called CD20, and so that targets something outside the cell. Whereas something like, say, for example, ibrutinib and zanubrutinib is a BTK inhibitor, so it's targeting this enzyme that's within the cell here that kind of blocks off this pathway that we know is overactive. So you can see here, I'm not sure how well it's you can all see it on your computers, but there are different targets to different enzymes that are being investigated in those early phase trials. So you'll see that there's lots of drugs that target this enzyme called PI3 kinase. There are some that are called Syk inhibitors that target this, form this Syk protein that forms a complex with BTK, and there's others as well that target AKT or this mTOR. But then there's also other drugs that are being developed that target the different proteins on the surface. So for example, this CD19 is targeted by some of the CAR T cell therapies that we are using now in other lymphomas. So as I said, one of the things is, apart from all these different proteins and enzymes to target, it's how to target it. So there's lots of tablets that tend to target the different enzymes that are overactive. And then the antibody therapies are the ones that target the proteins on the surface of the cell. So you might have antibody therapies that are naked antibodies, we call them, so that they just target the CD20, for example, like rituximab does, and causes cell death that way. There are some antibody drug conjugates where you've got something, an antibody that targets a protein on the surface, but it's attached to a chemotherapy drug or a radiotherapy drug that kills the cell in that way. And then there are a new class of drugs that are being trialed called bispecifics, which target a protein on the lymphoma cells, but also target a protein that's on your T cells, your T lymphocytes. And essentially, in a, again, very simplistic way of thinking about it, it brings your T cells towards your lymphoma cells and encourages your T cells to kill the lymphoma cells. So it's a way of using your own immune cells to try and target the lymphoma cells. And that's not that far off CAR T therapy, which I know many of you may have heard about, because it's, I guess, a revolutionary way in the past 5-10 years of treating high-grade lymphoma. But there are trials that are now increasingly looking at low-grade lymphomas, including WM. And I think there's one that's in setup with us and at UCH, and I think also a number of centers that may be open in the next 6 months or so. So just because I know a lot of you will have heard about CAR T therapy, this has been lifted from the CRUK website. But essentially, again, it's using your own immune cells to fight the lymphoma, essentially. So that you get your T cells collected from you, and then they are changed in the lab to express a receptor that will target your lymphoma cells. So the CAR T therapy we use for high-grade lymphoma targets something called CD19, which is on the surface of the lymphoma cells. So we use this, we kind of grow them up once they're expressing this receptor targeting CD19 so that you get lots of them. And then they're reinfused back into your body. And then the CAR T, from this honing mechanism, really goes, and the idea is then that it kills the lymphoma cells. So as I say, it's been successful in high-grade lymphoma and is currently in clinical trials for other types of lymphoma. So as well as kind of in terms of future treatments, we're looking at different targets, different ways of targeting those targets, but also something of interest is with all these targeted treatments that we know that there's certain kind of recurrent ways that people can become resistant to those treatments. And is there some way of overcoming that resistance? So by resistance, I mean, you know, if you're taking ibrutinib, for example, and it starts to stop working, what may be the cause of it stopping working? And is there anything that we can do to help it work again? So for example, with ibrutinib, we know that eventually the cells often develop a mutation which stop the ibrutinib binding to that BTK, and then that stops the ibrutinib working. But now there are newer drugs that target BTK, but target it in a different place, if you like, compared to the ibrutinib. Again, simplistic way of thinking about it, but that means that we can still use a BTK inhibitor, but that because it works in a slightly different way on the same enzyme, that it would have an effect even when ibrutinib or zanubrutinib has lost its effect potentially. So mechanisms of resistance is also an interesting area of research, because then it helps us kind of look for newer ways of targeting the same targets. So some of you may have heard about things like pirtobrutinib. It's called LOXO-305, which is, as I said, a different way of targeting the same BTK inhibitors, so that even when the ibrutinib, for example, has lost its effect, then you could still potentially get an effect with pirtobrutinib. And there's other drugs that have a similar vein. And there's also a clinical trial, for example, that we're running at the Marsden, where rather than inhibiting the enzyme, it's the drug is a degrader of that enzyme. So again, the theory is that even if you're resistant to zanubrutinib or ibrutinib, that potentially this treatment may work. And then the other thing that we think of, and one of the trials that's going to be discussed in ASH this year, is it right to give a targeted therapy that is useful and effective just as a single agent on its own, or should we be giving combinations to try and get a deeper response, to maybe mean that you don't need to take it long term but have a fixed duration therapy, then a time off treatment, and then be able to use it again? And you know, we have similar things like this in another blood cancer called CLL, and there are trials that are underway in WM looking to see combinations of targeted therapies, whether that would be helpful. And I think I've talked for long enough, so I'm going to stop sharing and actually give you all a chance to ask questions.
Thank you so much, Dima. That was so interesting. And I've just got an observation, really. You talking about, before you came on, I was telling the guys how lucky I was to go to Madrid and to the workshop. And the big take home for me there was, if you're offered a clinical trial, take the chance to do it. It's very, very important for the development of these treatments. But looking at your slide there, I felt a little bit sort of fraudulent, because only 3% of them like get to fruition. But I think you would agree, wouldn't you, still, that we should still, if you're offered a trial, it's of a good standard, it's of gold standard and above anyway, and that we should at least consider doing the trial. Is that good advice?
I definitely think so, because I mean, like, say for example, the acalabrutinib trial, we know it's effective. So if you were on that trial, you would have got an effective drug, even if the drug company have chosen not to proceed and take it further. It's not that because it didn't work. So, and we know that people that go on to clinical trials seem to do better than people that don't. And there's a lot of confounding factors in that. So it's not that I'm saying if you go on a clinical trial, you will definitely do better. We know that people that go on to clinical trials are generally more motivated, shall we say, and more likely to take good care of themselves, more likely to be fitter patients because they have to get through the eligibility criteria. So there's a lot of confounding factors, but there does seem to be some personal benefit. You may get drugs that are useful for you, but also I'm always amazed at how altruistic you all are. And you know, a lot of people, when you ask them why they've gone onto a clinical trial, it's, well, I had access to drugs based on clinical trials from people that were there before me, that I want to help the future WMers.
That's right. And I said only on my talk last week that, you know, I did BNR and some of us did DRC. Once upon a time, those were clinical trials, weren't they?
Exactly.
And,
exactly.
So that's good. So has anybody got any questions? I can't see any yellow hands up. So like I say, if you go to the bottom of your screen, reactions, press on that. I can see somebody waving at me. Hold on. And then you go into the little box and raise hand. That will alert me. But already I can see Bob Bassett. So Bob, come off mute and give us your question.
Hi, my question is, I started on ibrutinib beginning of this year, and I did have an initial response, but then about 2 months ago, it just flattened out. So I've now stopped ibrutinib, partly because of a lot of side effects, and partly because it was no longer effective. So I'm just wondering, is zanubrutinib going to be any different? Or is it a stop on both of the BTK inhibitors?
So it could be either. It kind of depends on, because you hadn't been on it for very long if you've only recently started it this year. So I guess it depends. Is it that you had a bit of a response, but then it plateaued, but you stopped because of side effects, in which case potentially zanubrutinib may help. But if you truly were kind of, the disease was coming back whilst on ibrutinib, the likelihood is zanubrutinib wouldn't be effective. We know that it's unlikely to be effective if you've had true progression on ibrutinib, but without knowing more details on your personal situation, it would be difficult to be absolute on that.
Yeah, I understand that. My particular problem is light chain, an excess of light chains, and they fell from 280 down to a low point of 109, and then it gradually started creeping up again. And my consultant said, well, if you're really struggling with the side effects, you're not having much benefit anyway. So hence I've stopped.
So, yeah, I mean, I think if it's more the side effects and there was just a little rise again, there may be a benefit in trying zanubrutinib.
Okay, thank you.
Thanks for that question, Bob. And just I forgot to warn you all or advise you all. So just remember this is a generic meeting. Dima's not your doctor. She doesn't know your case history. So try and keep it generic. And I'm going to go to Craig next. Craig, you're new to the group as far as I'm concerned. So welcome. And what's your question?
Thank you. My question is, if we were to release you from any responsibility for an accuracy of the forecast, but you were asked to forecast what drug, what approach, what method would be promising in the next 3 to 5 years, what would you pick? You're not going to be monitored. No one's going to hold you responsible for the forecast.
Well, you say that, but this is recorded, and I know that WMUK will put it on their website. But
well,
to be honest, I've given up trying to guess because there's so many other factors that are driven by the main aims of the pharmaceutical companies that I think that sometimes that dictates what ends up proceeding and being and used widespread in WM. And I'm going to be honest with you that because WM is relatively rare compared to other B-cell malignancies, I think that some of these drugs, which we know are effective in CLL, which is more frequent, that the companies will focus on other diseases where they may get more money. So for example, an example of that is there's some good data with another targeted therapy called venetoclax that targets a different enzyme to ibrutinib and zanubrutinib, and it's very effective in CLL, and we've been using it for many years in CLL, but it's also been trialed in WM and shown to be effective in WM, but the company that make it have never proceeded with a license for it. I think where the general field is going is with more of the immunotherapies and kind of looking at different ways of targeting lymphoid malignancies such as WM. So the bispecifics are a big field and CAR T is a big field as well.
Thank you.
Thank you, Dima. I'm going to take 3 more questions because I'm conscious we're nearly at the end of our hour. So I'm going to go to Sandra now, and then Tom, and then John. So Sandra.
Hi, thank you. It's a really short, not really a question even, but just to say that I'm on the Loxo 305, which is pirtobrutinib, and doing amazingly well. But I hope you don't mind me saying, Bob, Blood Cancer UK, which does some great work, they have a nurse that is dedicated to supporting people if they are making a decision about a drug trial. So if you're offered a drug trial and you're a bit unsure, you're not quite, you want more info and want someone independent from your team to talk about it, they have a nurse dedicated to that. She's also very good at looking up to see what trials are available. So if people were interested, they could try Blood Cancer UK.
Thank you for that, Sandra. And as
Can
you may, well, I'm going to, yeah. Please, Dima. Sorry. Yeah.
I was just going to say that that's really useful to know. So thank you, Sandra, for letting us know. But now that we've got the phone line set up with WMUK, that is something that we can definitely look at developing with Alison there.
Yeah,
that's exactly what I was going to say, Dima. We've got you guys will meet Alison next Saturday when we launch her as our support line manager. She is a nurse. She works at the Marsden, I think, Dima, doesn't she? Or she did.
Used to, yeah.
Yeah, so lovely nurse called Alison, and she's going to be answering those kind of questions, not right from the get-go because she's never been involved in WM before, but she's working very, very hard to catch up. In fact, this week she's in clinic with Shirley Dessar, so she's really working hard to catch up. So thanks for that. And then Tom, you're next.
Yeah, thanks, Bob. Mine's a bit of a sort of naive question in a way. I'm familiar with relapsed situation, but refractory?
So relapse is the disease goes and it comes back. Refractory means the disease never went. So
Fine.
we often lump the two together.
Okay.
So when you see relapsed refractory, yeah, it's that the disease has either come back or it's never gone. Usually refractory is a sign of more aggressive disease because it hasn't responded at all to the drug.
Fine. Thank you very much.
No
Tom, I love that question. Quick story. I was in Madrid and Suzanne Ardigan was sat behind me. She's from UCLH. And they were talking about relapse and refractory. And I wrote, Suzanne, what is the difference between relapse and refractory? And she wrote me an essay, which was great. And thanks for that. So, John Green.
Right, just a quick question. The fact that ibrutinib has now been rejected as cost effective, how's that sort of balanced with the Rainbow trial, which, yes, I know ibrutinib will be funded through that trial, but the Rainbow trial was sort of touted as being quite an important trial to compare DRC versus ibrutinib rituximab. And I just wonder how
John, you've asked a very interesting question there, and one that we talk about as clinicians, but I think it's a sign of how much bureaucracy there is in setting up a clinical trial, that you would not believe how many years it takes to get a trial off the ground, that actually by the time it's running, that it may not be asking directly as important question as it was when you first studied and started the trial. However, having said that, you know, a lot of the trials don't compare chemoimmunotherapy to BTK inhibitor, and there is still zanubrutinib, which we know has a different side effect profile, but efficacy-wise seems to be very similar to ibrutinib. So it's not ideal to extrapolate, I know, between different molecules, even though they're the same family of drugs. But I think the outcomes will still be very interesting, although not directly relevant, because as you say, we don't have access to ibrutinib now.
Right. Thank you very much, Dima, and thank you for a very informative presentation.
Oh, thank you.
Thanks, John. Thanks for that question. So, Dima, just we've got 5 minutes left. I just want to say a big thank you to you for joining us tonight. I'm glad your school interview went well, because I dread to think how it might have been if it didn't.
Yeah.
But that was really interesting, and thank you so much. And I just want to remind everybody that Dima is very kindly going to come and talk to us in Birmingham in 9 days' time. She's been covering all things COVID and Evusheld, which is going to be a story in itself, I'm sure, and all those kind of things. So we look forward to seeing you there, Dima. And guys, it's not too late to register. We've still got a few spaces for live attendance, or you can register to join us online and watch from your computers, which is great. So Dima, just a massive thank you so much for tonight. Really appreciate it. As always, Dima always gives us her time freely, and we thank you so much for that.
Yeah.
Oh, no problems. It was my pleasure. And
Good.
I hope to see many of you next weekend.
Good. And guys, I'm going to hang around when we log out in a minute. I'm going to hang around. So if anybody wants to wait and ask me anything at the end or thing. But like I said, in Madrid, 2 big take homes, clinical trials. If you're offered them, go for them. And remember, we are going to be pushing you for your data from now for the next 5 years, because we want all your data so that we don't have this zanubrutinib issue with NICE again when the next new drug comes along. Dima, you're going to say something.
I definitely think that's very important, because they will take NICE will take real world data into account. So if we can give them the comparison, even if the trial doesn't, they will take that into account.
Yeah. And for those of you that don't know, we've got the Rory Morrison registry, which sadly not all of our centres are signed up to. We've got a lady working very hard at the moment to try and get all of our centres on the Rory Morrison registry. Big thank you to Roger Brown, who's still with us, because he helped that set up right at the beginning. Our PROMS data, which you can get sent to you every 3 months. That's your sort of quality of life data. It's not brilliant, it's not perfect, but it's something, and we are going to improve that. And then there's the whimsical project that comes out of Australia, but it's global. And all of these things, they agreed in Madrid last week. We've got to get more real world data to get these regulatory organizations to fund our drugs. So data, just keep thinking about it. And I'm going to be harping on about it for the next 5 years. So anyway, Dima, thank you so much. And I'm going to hang around, guys, if you want to talk at the end. Some people saying thanks and everything. Yes, Michael Lawrence, my video has gone off. I don't know why. It's since I held that bit of paper up, but anyway. Anyway, guys, thank you so much. I'll hang around till the end. Roger, big thank you to you for joining us tonight. Thank you for all you did. For you are Mr. WMUK right at the beginning. So thank you for that. And it's great to see you again. It's great to see you. And I hope you're going to come to not Nottingham, to Birmingham even, and see us.
Yeah.
Okay, bye everyone.
Thanks, Dima. Bye. Bye.
Thanks, Roger. Bye, Bob.
Bye.
Leave.
And then there were 9. So I'm thinking, have I got time for 9 questions? But come on, let's go. 8. Who wants to go first? Put your hand up. Anybody? John, go on, John.
The other day you mentioned that when you were at the meeting in Madrid, you raised the issue of if you needed to have BR again, would you be offered it? And I think, you know, there's 2 schools of thought from the sort of clinicians as to whether you would be offered a repeat dose of your initial therapy. And I remember you saying you were going to raise that issue with Helen McCarthy when you saw her.
I saw her this morning, and it was such a brilliant meeting, and I was so delighted with my results. I forgot to ask her.
Fair enough.
But I did ask her in Madrid, and she just smiled and said, "Yes, I would consider it, but I'd rather put." But the German doctor I spoke to, which is what I said on that meeting, he said, "If I was your doctor, I'd be giving it you BNR again because it's 6 years since you last had it." Right. So I would recommend it to you again. So yes, I've got that conversation. I've got it in my back pocket for later, I guess. Yeah. Right. And who knows? There is a trial going on somewhere in the world into that subject. So who knows? By the time I come up for treatment again, it might have been resolved.
Well, the trial of a repeat.
Yeah, I think in Germany, that German guy, I think they're doing it there. They're checking it out. So and seeing what kind of response they get. Yeah.
Okay, thanks, Bob.
Good. Okay, John. Bob Bassett, are you waiting to talk to me?
No, I'm all right, thanks, Bob. Sorry about overstepping. I didn't intend to do that.
No, don't worry about it. It was my fault. I always give the warning, and I forgot.
No, well, I know the warning. It's just transfer.
Otherwise, we end up with where there were 48 of us, we would end up with 48 surgeries, and she doesn't know any one of us. So
no, that's
yeah. Okay, thanks. Okay, then, Bob. Keith.
Yeah, Bob. It's just a thought of BR versus DRC. Is there any WMUK thoughts on that, or is it individual?
As first-line treatment?
Yes.
Yeah, that's down to your clinician. But what we do know is that so the BR is a more robust, more toxic chemoimmunotherapy. Yep. So there will be some sort of assessment done as to like what your age is, what your health is, how robust you personally are, whether to give you BR or the more sedate but equally as effective DRC. It is at the end of the day down to your clinician in conversation with yourself. But I think knowing what I know now, I would, if I was going in, knowing what I know now, if I was going in as a new patient tomorrow and she said, "I'm going to put you on DRC," I would say, "Can't I go on BR then? Why can't I go on BR? Because that might give me a longer remission." Might not, of course, but it might do. But that's knowing what I know now. And of course, none of us know that, do we, when we're diagnosed? So.
But wouldn't you run into trouble with this issue of
Yeah,
the
for sure.
use of zanubrutinib?
You would now, right now, you would, because if you started with BR, then it's possible your clinician might not consider you for or couldn't consider you for zanubrutinib, in which case you'd have to go onto DRC as your second line. So yeah, that is now becoming an issue, not particularly for us old guys on this screen, but for our younger people who may be robust enough to take BR. Are they now going to be thinking, yeah, but if I have that, I won't be able to go on to zanubrutinib, so let me try DRC first? Yeah, so it's a big dilemma that's going to be coming along. Yeah. And Gordon, Gordon, you've raised your hand there. You come off mute. You need to come off mute.
I have done, yeah. Hi there.
Yeah.
Thanks for the invite today. One question, which I didn't have a chance to ask.
Yeah.
Is there any indication of rituximab knocking out the white cells and neutrophils, and for any length of time?
Oh, yeah. Well, I can't answer that. I'm not a doctor. We should have got that one into Dima, but yeah. Let me Gordon, send me. Oh, you couldn't work out. You should have just waved at me. Just keep waving at me. Gordon, just be good enough to. Are you coming to Birmingham or not?
No, I can't.
No, you're not. No, because you're on treatment, aren't you? So, would you be good enough to just send me an email tonight or tomorrow with that question, and I will get you an answer. Yeah.
Yeah, I've seen neurologist finally, and apparently the axonal neuropathy, which I am now suffering from, I've got a name for it at last, is down to bendamustine.
Oh, really? Okay.
So I've been told.
Wow. Well, okay. All right then, guys. Well, lovely to see you all. So, Bob, don't forget we're down your neck of the woods in a couple of weeks' time, going over the Brecons.
Yeah, I wish you well, but I don't think I can even get as far as I did with you last time.
Well, wave to us from a distance. Wave to us, or come along and join Fleur. She's going to be on the A. Is it the A47? She's going to be there at the car park with a flask of coffee for us at the halfway point.
The 470, yeah.
Yeah, so we'll be getting there about, I guess, between 11 and 12.
Unfortunately, my family signed me up to go to
Oh, okay. Okay. All right. No problem. All right. Good. Okay, gang.
How many's doing the walk, Bob?
Oh, there's about 20 of us, not all patients. There's 3 doctors, 2 nurses, about 5 or 6 patients, and then 2 or 3 sons, daughters, and then I've got 6 of my old army mates are going to come along for safety.
So they're going to carry the rest, are they?
They're going to carry carry anyone down who needs bringing off the mountain, because I've got to lead from the front and do the whole lot. So they're going to be looking out for people, and if anybody's struggling, because my brother went up last Saturday, and you can vouch for this, Bob. My brother went up last Saturday. He sent me a video. It was horrendous. Yeah. So I hope the weather's not like that in 2 weeks' time. But there we go. Okay, guys, take care. Lovely to see you all. Take care. Bye-bye.
Bye.
Bye.